Our topic tonight is Men's Health Matters, What Every Man Should Know. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Desai Sethi Urology Institute. The Desai Sethi Urology Institute's mission is to deliver excellence in clinical care, to improve patient care through cutting-edge research, and to empower the next generation of urologists. They've assembled the largest group of fellowship-trained subspecialty leaders in the region. Many of these experts have been recruited from first-class institutions and are sought after both nationally and globally. They're clinicians with a proven track record of excellence, catering to patient needs with personalized care. We invite you to learn more about the Desai Sethi Urology Institute by visiting umiamihealth.org/urology. Contact them to schedule a consultation by calling 305-243-6090. We're going to repeat that information at the end of the webinar, so you'll be able to see it again, and you'll have the contact information. Tonight, our esteemed panel will delve into some of the most prevalent topics surrounding men's health, including common benign and cancerous prostate conditions and when these disorders require treatment. Who should be screened for prostate cancer, how the process works, and why early detection is important. The safety of testosterone therapy and its role after prostate cancer treatment, and erectile dysfunction, its causes, potential for reversal, and available treatment options. Our speakers are Bruce Kava, MD, Professor and Director of Men's Health at Desai Sethi; Thomas Masterson, MD, Assistant Professor of Urology at the Urology Institute; Laura Horodisky, Assistant Professor, Residency Associate Program Director of Desai Sethi Urology Institute. And at the end of the presentation, you're going to have a unique opportunity to do a Q&A session and ask direct questions of our experts. So please use the Q&A feature at the bottom of your Zoom screen to enter your questions, and we'll tee them up for our experts. So let's begin. It's my pleasure to introduce our first speaker, Dr. Thomas Masterson, an assistant professor of clinical urology. He has experience using standard operating optical microscopes and 3D video microscopes for surgeries. His research interests include treatment of male infertility, fertility preservation, testosterone replacement, and male sexual dysfunction. Let's welcome Dr. Masterson tonight.
All right. Thank you very much for the introduction. So we'll just kick right into it. So today we're going to be talking about testosterone replacement therapy and its relation with prostate cancer. So in the news right now, prostate cancer is basically everywhere. I think everyone at this point has heard that former President Joe Biden is suffering from prostate cancer. But what I want to tell you is this is a very common problem, right? Approximately 1 in 8 men will develop prostate cancer in their lifetime. And 1 out of 44 actually die from prostate cancer. And that's not 1 out of 44 men diagnosed, but actually 1 out of 44 men can expect to die from prostate cancer. So there's a huge discrepancy between those numbers. And really what the takeaway here is that for most men, prostate cancer is chronic disease, which means you're going to be living a long time either with prostate cancer or after treatment. Now, in that same age group of patients, we have the disease process of low testosterone. As men age, our testosterone levels do start to decline. And by the 6th and 7th decade of life, right, as many as 40% of men may suffer from low testosterone. So what happens is we have this population of men who have prostate cancer, who may later develop low testosterone, and this becomes controversial what to do about them. So why is this controversial? Well, the relationship between prostate cancer growth and testosterone dates back to the 1940s, where in this one paper, these Huggins and Hodges basically observed that when they castrated people with advanced prostate cancer, their prostate cancer actually shrank. And they saw that in men with advanced prostate cancer, when they gave testosterone, the cancer grew. So it sort of became dogmatic that testosterone and prostate cancer seem to be related to each other. And truly, this became what we all thought for years, for decades. In fact, they even won a Nobel Prize. But keep in mind, our understanding of medical knowledge increases over time. What were some of the other things we were doing in the 1940s that we don't do anymore? Well, we used to X-ray people's feet to make sure that their shoes fit. We now realize that this caused sarcoma in a lot of patients who otherwise wouldn't have had it. The 1940s was also when we saw the introduction of the lobotomy, something that we really don't do anymore. So let's revisit this thought. Does testosterone actually cause prostate cancer? Well, we don't have any huge randomized studies to really answer this question. But what we do have are smaller studies that look at this. Now, in this table, it's a little bit wordy. What I want you to understand is that in these cohorts 1, 2, and 3, these were men who were placed on testosterone therapy for low testosterone. They compared the incidence of prostate cancer into these other two trials, the PLCO and the ESRCP. These were basically population-based trials just looking to see what is the incidence of prostate cancer. And what we actually see is in the men treated with testosterone therapy had a lower incidence of prostate cancer compared to the general population. So again, there's probably some confounding information onto this, but what I want you to understand is it's probably not a causative thing, that testosterone therapy probably does not cause prostate cancer. The most recent information we have is something out of the Traverse trial. This was a prospective trial, meaning they recruited patients, right, and treated them with testosterone therapy or placebo. And what they were looking at was actually cardiac events. But when they have such a large patient population, they wanted to see, well, did the men in the testosterone group develop more prostate cancer? Well, the answer to that was no. The men receiving testosterone therapy did not develop prostate cancer at a higher rate compared to the men who received placebo. So the takeaway from this is generally we believe that testosterone therapy does not cause prostate cancer. But what about the other group of patients, right? If we believe, all right, we're not causing prostate cancer with testosterone therapy. If we give testosterone to somebody who's already had prostate cancer treated, are we putting them at risk of prostate cancer recurrence? So again, we don't have any great prospective data, but we do have lots of retrospective, meaning looking back, right? Patients who had prostate cancer removed in surgery, right? Looking to see how many of those patients afterwards had low testosterone, were put on testosterone therapy. So again, it is controversial to put these patients onto testosterone. So there's not that many in this group, but at least in this 198 patients, when they compared them to the 5,000 who did not receive testosterone, there was no difference in PSA recurrence. There was no difference in prostate cancer recurrence, and there was no difference in prostate cancer deaths. So again, it appears that testosterone therapy after prostate surgery is safe. Well, what about radiation therapy? This is the other main group of treatments for prostate cancer. Again, we don't have great prospective data, but we look back at what's been done in the past, right? Looking through VA data of over 40,000 patients who received radiation for prostate cancer. Of them, about 500 received testosterone later. And once again, we saw no difference in prostate cancer recurrence, PSA recurrence, death from prostate cancer. So again, after surgery or after radiation, testosterone appears to be safe. Now, what about men on active surveillance? So these would be the men who elected not to have their prostate cancer treated, but watched over a series of years to see whether it advances. Well, this is very controversial, right? Because these men still have active prostate cancer. And now we're asking, is it safe to put them on testosterone therapy? Are we potentially feeding the cancer? So the only good study we have on this, again, retrospective, they looked at men who'd had low grade, low risk prostate cancer and low testosterone, right? And put them on testosterone therapy. Again, only about 160 patients, but still what we saw was that there was really no difference in prostate cancer advancement, PSA, or prostate cancer death. So again, it appears to be safe. So in summary, the takeaway from this talk should be that testosterone therapy appears to be safe and does not cause prostate cancer. Testosterone therapy appears to be safe in men who've had their prostate cancer treated. It's still controversial whether or not you can safely put a man with prostate cancer and active surveillance onto testosterone therapy. And with that, I'll conclude this portion.
Thank you very much, Dr. Masterson. Our next speaker is Dr. Laura Horodisky, a urologist with specialized training in trauma and reconstruction. She's passionate about helping patients with the best medical and surgical care, and most recently became the first surgeon in South Florida to offer transurethral incision with transverse mucosal realignment. That's a minimally invasive procedure to treat bladder neck contracture. Let's welcome her, Dr. Horodisky.
Thank you so much. Just a moment so I can share my screen.
Oh, I apologize.
Okay, so thank you so much, Eliana, for that introduction. So what I would like everyone to know who's on this talk today is that if you're struggling with erectile dysfunction, you're truly not alone. This is a very common problem that affects men as they get older. In fact, about 50% of men in their 50s have encountered some sort of trouble with erections, and men that are younger can still have these problems. It does increase with age, and this can be affected by medical issues. It also can be affected by psychological issues. Stress, depression, issues in a relationship can also affect erectile function. And there are a ton of effective treatments, and we'll be going over those today. So I wanted to give you first just a little bit of information about how the erections work. So this is a cross section of the penis. The penis is made of 3 cylinders. There's 2 on the top. These are the erectile bodies, or the corpora cavernosa, and then the urethra beneath that, which is the tube that you pee through. When you get an erection, the corpora cavernosa and the urethra to some extent fill with blood, and the blood is supplied by these arteries running along the top of the penis. These arteries also go into the corpora cavernosa. Now, the blood vessels, the arteries here, are very small. They're about a millimeter across. And when we think about blood vessels other places in the body, these are some of the smallest ones that actually have names. When they get too small, we don't even assign them any names. For example, the blood vessels in the heart are about 6 millimeters, so 6 times the size of the blood vessels in the penis. So that gives us an idea of how small they are. So going back to contributing causes, there are a lot of things that contribute to it. What I want you to know is that erectile dysfunction is a problem with most often the vasculature, the blood vessels that supply the blood to the penis. And wear and tear on these blood vessels can be accelerated by high blood pressure, diabetes. Patients with coronary artery disease have high risk of having erectile dysfunction. And on the flip side of that, men that start to experience erectile dysfunction also are at increased risk of heart attack or developing coronary artery disease. That's because the same thing that is affecting the blood vessels in the penis is affecting the blood vessels in the heart. So it's important that you're looking at your overall health and working with your primary doctor to make sure that you're optimizing your health. Some medications can affect erections. So some medications for blood pressure, including beta blockers, antidepressants or mood stabilizers, some antihistamines, so Benadryl, which is actually a very common sleep aid, like something in NyQuil, and also treatment for Parkinson's. As I mentioned before, stress, depression, or relationship issues can affect erectile function. And alcohol, which is a depressant, can make it more difficult to get and maintain an erection. Sometimes we see that men with low testosterone can be linked to erectile dysfunction, although most often when testosterone level gets replaced with testosterone therapy, like Dr. Masterson was talking about, we first see an improvement in libido, to a lesser extent to an improvement in erectile function. Neurologic issues can also affect erections, so things like multiple sclerosis, spinal issues, prior trauma, surgery down deep in the pelvis, pelvic floor muscle dysfunction, which is a condition that more often affects younger men. And there's also studies showing that excess pornography consumption can contribute to erectile dysfunction. So going back to my earlier point, erectile health is cardiovascular health. So anything that you can do to improve your health will improve and help you maintain your erections for hopefully a long time. So eating healthy and exercise are always number one, but also quitting smoking. And going along with that, there's a lot of other nicotine products out there. So chewing tobacco, the vaping, or nicotine troches like Zyn, they all contain nicotine, which causes vasoconstriction of the arteries. And when the arteries constrict or squeeze down, that does reduce blood flow. So when used chronically over a long time, this can adversely affect your heart and also your erections. Controlling blood pressure, diabetes are also all going to be helpful. Now, going into treatment options, there are a lot. I really like to tell patients in this day and age, if you are motivated and willing to try a gamut of things, we can work with you to help you get an erection. So this can be starting with things like medications such as Viagra or Cialis, the very popular little blue pill that I think many patients have heard of. Also, vacuum erection devices, which fit over the penis and provide a suction that helps to pull blood into the penis. These are often combined with a constriction band, you can see down at the bottom here, that fit around the base of the erection to help to maintain the blood in the penis. If you think of an erection, it's like you're trying to fill up a bathtub. So you both need blood flow coming in, and then you need to prevent the blood from coming out. You need a drain stopper. So I think the vacuum erection device really demonstrates both, where you have the suction effect forcing blood into the penis, and then the constriction band preventing it from leaving. There are also injections that can be used. So this is something that can be called ICI for intracavernosal injections. Trimix, bimix, or quadmix are all common names for this. This is an injection that's given into the side of the penis with a tiny insulin needle about 10 to 15 minutes before sexual activity and is stronger than pills or the vacuum device. And finally, the penile implant. There are two main ways that, or types of penile implants. There's one that bends up and down, which is less common but good for men who have issues with their hand dexterity. And then the more common inflatable implant, which is the one here, which has a pump inside the scrotum that you pump, and it's a hydraulic system. It brings fluid into the cylinders, which are inside the penis, to maintain an erection. There is also a deflate button on this pump, so when you're finished with sexual activity, you can deflate the implant and go back to a flaccid state. So I hope this gives you a good overview of some of the popular treatments, and then there's many other things out on the market. One of the things out there is something called low-intensity shockwave therapy. This is being used in Europe for some men who have vascular disease and is gaining popularity in the US as well. This is shock waves that are delivered to the penis and can help potentially improve blood flow. It's definitely safe. It may not be effective for all men. Also, some patients have done PRP injections or platelet-rich plasma. So this is plasma that's separated from the patient's blood and then injected back into the penis. This has been found to be safe, but not really effective for improving erections, so I generally don't recommend it to patients. Finally, some patients try over-the-counter supplements. There's about 1 million male performance supplements out there. I really recommend you proceed with caution with these because supplements are unregulated. You really don't know what ingredients are going to be in there. They may be things that could interact with other medications. There's risks of taking supplements and having liver problems or even liver failure. And the efficacy is going to be very variable depending on the ingredients. I really think it's much safer to try something that has been proven and tested and that you know is safe. All right, so I hope that gave you a great overview of erectile function, what's out there, and how we can help. And if you're dealing with this, just know that you're not alone and we're here to help. Thank you.
Thank you, Horatisky. We appreciate it. And we are now going to tee up our final speaker, Dr. Bruce Kava, a distinguished expert in men's health with particular expertise in urologic oncology, sexual dysfunction, and BPH. He's the current president of the American Society for Men's Health and has served on the editorial board of the Journal of Sexual Medicine, as well as the board of directors for the Florida Urological Association. Let's welcome Dr. Kava.
Thank you so much. Let me just tee up everything here. Thank you. I just want to thank my colleagues who did a fantastic job. Wonderful presentations, both of you. And Ileana, thank you for this is I think this is the third time that we've all done this. And I love it. I look forward to it every year because these discussions, between Dr. Horoditsky and Dr. Masterson, so timely, so time. Everything is really like on the mark. And I think that we should continue, maybe even plan on doing these more often than just once a year to celebrate and commemorate Men's Health Month. But I think it would be great. Thank you. Thank you. So I was given the talk on benign and malignant prostate disorders, what every man should know. And the reason why, I mean, with the news, what's going on with President Biden, I think it's a really important area to discuss. The first area that I'll be talking about is the benign disorders of the prostate, which impact a lot of us. It really does. You know, if you ask the average urologist what exactly the prostate does after all these years of studying this organ, many of us still don't know exactly all the things that it does. It does contribute. It produces fluid, which helps nourish the sperm. It helps liquefy the ejaculate fluid to allow for impregnation. But other than that, we don't really know a lot else that the prostate does, except to cause, as my father would say, psoas for so many men, between the benign growth and the malignant growth that happens over time. Bigger is not always better, as we've all learned. And if you see on the graph on the right side of the screen here, at around age 30 to 35, in most men, the prostate begins a growth cycle. There are a lot of things that contribute to this. A lot of it is related to testosterone and other androgens and other hormones in the body. But at some point at the age 30, 35, there's a growth spurt that occurs. I wish it happened to my height, but in fact, it happened to my prostate instead. But I think that most of us, it starts to occur at that point. And at some point in time, most men will begin to experience some symptoms related to the growing prostate. The growth in the prostate does lead to lower urinary tract symptoms. In some cases, the symptoms may become so severe that frank urinary retention may occur. Recurrent urinary tract infections and bladder stones occur in some individuals. And again, in some individuals, they may develop blood in the urine as a result. The symptoms that occur as a result of the growth of the prostate, this is, again, we're talking about benign growth, are now categorized into three classes. Storage symptoms, which include frequency, waking up at night, urgency, both in the daytime and nighttime. And then there are avoiding symptoms like the slow stream, intermittency, straining to get the urine out. And then there's post-micturition symptoms. This is the third category, which just indicates incomplete emptying. We take these three categories of symptoms and have put them into a questionnaire, which we see on the right side of the screen there, which most urologists will have in their office. They'll distribute them to you at the time of your first visit. And it's called the International Prostate Symptom Score. And what that does, it basically categorizes the severity of the symptoms that you experience. It's a questionnaire consisting of 7 questions. Each one has a grading scale between 0 and 5, 5 being the most abnormal or the worst, and 0 being the least bothersome. And so the total score of this 7 questions is 35, indicating severe symptoms, and 0 would indicate less severe. What we can actually do, the symptom severity, we actually classify into 3 categories: mild, moderate, and severe. Urologists are we kind of like to make it easy on ourselves. So mild, moderate, and severe. Those people with mild symptoms, we generally don't recommend active treatment for, something aggressive. But moderate and severe symptoms, depending on the bother on the individuals, that's how we focus on what we want to do for the individual and try to make their life better. Lower urinary tract symptoms affect a large population of patients. 2 separate studies from, well, the first one from the Boston area, looking at 5,500 patients, showed that 30% of men over 50 years old had either moderate or severe lower urinary tract symptoms based on the IBSS score. The EpiLUTS questionnaire, which was internet derived, basically looked at thousands of men across 3 different countries, and they found that at least 72% of men have at least one symptom at least sometimes. So the impact of this is staggering. It affects the majority of our population of men as they age. So most of these are not life-threatening. I mean, so waking up a couple of times at night, having to strain to get the urine out, maybe waiting in line on the movie theater trying to get the urine, when somebody in front of you is taking their time, it's bothersome, but that's what it is. It's bothersome to most people. The bothersome extends into, sleepless nights, running to the bathroom, seeing creepy urologists on occasion. But again, it's bothersome, not terribly, impactful on your overall life expectancy. But these numbers are staggering. BPH, or benign prostate enlargement, impacts 21 million men in the United States. And in fact, if you look at the cost of this, 12 million men are managed by either medications, monitoring, or surgery. And that we're talking about billions and billions of dollars, $15 to $20 billion a year that's spent on this. So it's important. It is an important health problem for men. Despite the fact that most men are just bothered by these symptoms, it does impact their overall quality of life. Now, there are some people, though, that it gets a little more severe and more worrisome. Those men that develop urinary retention, where they require a catheter placement, those men with recurrent urinary tract infections. I just had office hours. That's why I'm kind of rushed over here. And I saw at least 3 or 4 men with recurrent urinary tract infections today. Kidney problems as a result of the obstruction from the prostate occur on rare occasion, but they do occur. And then there's those people that develop blood in the urine. Most of the time, however, these severe problems don't occur. And most men come to us with moderate or severe symptoms. And they're so bothered by these that they want something done for it. First line therapy is usually medical. And we have other than lifestyle things. For some men who wake up a number of times at night, if this is the biggest part of their symptom complex, we'll usually tell them to restrict fluid at night. We'll do a whole variety of different lifestyle modifications. If they have sleep apnea, that's been known to contribute to this. If they're on some of the newer medications, the GLP-1s or something, that may contribute to some waking up at night to urinate. But most men who have significant symptomatology will recommend one of the medications for this, and that includes either alpha blocker, which includes tamsulosin, alfuzosin, or silodosin. Most men have heard about those. A 5-alpha reductase inhibitor, finasteride or dutasteride. And then there are a variety of medications that we use to calm the bladder down for those people with urgency. And so these are considered anticholinergic medications, and I've just listed them there. Interestingly enough, over the last 10, 15 years, we found that tadalafil, which is normally we equate that, as Dr. Horditsky mentioned, tadalafil with Cialis, we've equated that's been found to help improve the urinary flow and reduce some of the symptomatology for men. And then there are some people that will put on combination therapies using an alpha blocker and tadalafil, an alpha blocker and anticholinergic, 5-alpha reductase inhibitor and alpha blocker, whole variety of different things. When it comes down to it, about 35% of these men are unable to or unwilling to remain compliant with the medical therapy, though. These medications do cause side effects. They improve the urinary flow rate by maybe 2 or 3 milliliters per second. The symptom scores maybe improve a couple of points here or there. No tremendous changes. But again, we're talking about bother. We're talking about men who basically, most of us have a purpose in our lives that we're willing to put our bother with the urinary symptoms on the side so that we can feed our families, so that we can, engage with our wives, our partners, our spouses, or, there's so many things in our lives that are going on. And men are very good at compartmentalizing these problems, the bothersome urinary symptoms. But when it gets severe, the alpha blockers, the medications are a good start. If they don't work for the other men, for the 35% of men, or these men grow out of them, then we have other things that we can offer. Surgical therapy or minimally invasive surgical procedures are available, and we have a lot of them now. TURP was considered the gold, and it still is considered the gold standard for surgical therapy for BPH. It involves placing an instrument through the penis into the bladder. The patient is under anesthesia, and we're basically debulking or removing the inner portion of the prostate. The way I look at it, prostate's like a big orange, or we're taking the meaty part of the orange out, and leaving this shell on the outside and allowing now the urine to go through the prostate with a much more force, with reduced post-ward residual urine volumes and with improvement in the symptom scores. It's a wonderful procedure that has gotten a lot of bad press and through the internet and through a whole variety of things. There are a lot of people who've had problems years ago from these procedures, but most of the time now, the TURP, because of the tremendous improvements that we've had in our technology, it's so much safer, so much more effective, and it's done with experienced surgeons. You have a wonderful outcome with these. But there are still other options available, and there are a whole variety of them. I couldn't do this in a short period of time, but I'm just going to mention 3 minimally invasive options. This UroLift, which you're seeing the video on right now, involves implanting these implants in the prostate, which basically pulls the lobes over. This can be done in an outpatient setting with local anesthetic or either max or just a sedative. It's done very quickly, very rapidly, often without a catheter. And the patients report improvements in their urinary flow, reduced symptomatology, and reduced residual urine. Water vapor therapy, this is another one. This is where we put steam inside the prostate. It's called Resume is the name of it. And basically what you're seeing there is a steam being injected into the prostate and destroying the tissue in the middle of the prostate. And this works very, very well at destroying the inner portion of the prostate. There is a little bit of a recovery involved. It can be done in the outpatient setting, also with sedation or with local anesthetic. The one that I've been very high on recently is aquablation. Now, aquablation is a robotically driven water jet. So as a surgeon, I'm sitting there, most of my experience, you're asleep on the operating room table under general anesthesia. And a lot of the time, I'm actually planning what we're going to do. We have an ultrasound probe that shows me where the prostate is. I can program the robot to precisely resect the portions of the prostate using a water jet instead of electrical current. The cold water doesn't impact erectile function in any way, and we can preserve the ejaculatory function with this technology. What it does is basically it's almost like a windshield wiper using a water jet that shaves down the inside portion of the prostate. So as you can see, this is our surgical menu at this point, and it's incredible the number of different procedures that we can offer people. A lot of this depends on the prostate size. The average prostate size, smaller prostates, or large prostate, determine what types of modalities are available for your particular treatment. You can see the average prostate size. There are so many different treatments that are available. Used to be one size fits all with the TURP. Now we have multiple different things. Again, I think the aquablation right now can handle average prostates, as can green light lasers, as can holmium lasers, a whole variety of different laser therapies. The TURP, obviously, water vapor therapy, and also the UroLift. So with all these things available at this point, what we have seen tremendous improvements in safety, convalescence. We're allowing people now to decide what types of therapy they want based upon the prostate size and the clinical acumen that we have. So preference sensitive outcomes. We can preserve sexual and ejaculatory function, and their durability is getting better as well. We have people now out 2, 3, 5, 10 years after these procedures doing very, very well. I wanted to shift now a little bit to prostate cancer. We'll talk on the question and answer session more about some of the modalities available for BPH if you'd like. But I just want to talk a little bit about prostate cancer, because that's still, with President Biden, it really has become a timely topic of discussion. How did this happen? So prostate cancer still remains the #1 cancer diagnosed in the United States for men. 29% of all cancers diagnosed in the United States in males are prostate cancer. We're approaching 300,000 new cases a year. When we look at the mortality from this, it's the second leading cause of mortality in men. Worldwide, it's a little bit lower down because there are so many other problems that people have outside of the United States, like lung cancer, colorectal cancer, stomach cancer, a whole variety of different things. But prostate cancer remains a very prevalent cancer. The death rate is not as high because, again, people don't always live as long as we do here in the United States. We're very fortunate in so many ways. I thought I'd throw this in because this is incredible. These are the number of cancer deaths averted as a result of the many things, the developments in the cancer area that researchers and physicians have done over the last years. And you have to look at this in awe. I mean, I started my career someplace, I'm not going to say exactly, but someplace between 85 and 90. But that's when this tremendous improvement started. And what we can see is a 56% decline in lung cancer more deaths between 1990 and 2019. Colorectal cancer, 55% just by earlier screening. Screening in colorectal cancer, screening in lung cancer, and prostate cancer has also screening. The efforts in prostate cancer are unmatched in any other cancer, but we have a 53% reduction in mortality as a result. PSA is really the mainstay of our screening efforts, and it's been around since the late 1980s. It's an enzyme. It's made exclusively by the prostate gland, and it can be released as a result of a variety of different things. When you have cancer, obviously the PSA can be elevated, but other things like having an enlarged prostate, an infection of the prostate, or any manipulation of the prostate, a prostate biopsy or a prostate procedure will cause the PSA to go up. So what we've been using the PSA molecule for is for monitoring response to cancer treatment and also for screening. And that's where the difficulty comes because there's a lot of controversy about PSA-based screening. I just wanted to go into that today a little bit. The reason why PSA is so important, and this is, again, this was at the start of my career when PSA was starting, and this was the first data that I got to see, is if you look at, this is the Baltimore Longitudinal Aging Study. This is the power of PSA. If you look at the top group of people, that pale blue, those are patients with metastatic prostate cancer at 0.0 in time. Look on the right side of the screen. If you go back 5, 10, and 15 years earlier, if you look at their PSA values, they had gone from a very low PSA very quickly, exponentially, at time 0 and those were the patients with metastatic disease. Had we been able to find them earlier with PSA testing, at some point 15 or 20 years earlier, there's a very good chance those people would not have developed metastatic disease. And that's the power of PSA. As a result of this data and a lot of other data that was accrued, this is the AUA best practice statement in 2009. I'm saying this for a reason. But in 2009, men 40 to 50 years old with a life expectancy of more than 10 years, baseline PSA should be obtained. Then annually, a rectal exam and a serum PSA. If any of those are abnormal, then we would recommend doing a transrectal ultrasound guided prostate biopsy. 2009. A lot has occurred since then. We've realized that not every man with prostate cancer needs to be detected. Not every man with prostate cancer needs to be treated because in many cases, it's a very prolonged natural history. We've also learned that PSA very often overdiagnoses cancer or has a very high false positive rate, meaning that there are a lot of patients out there with elevated PSAs that don't have cancer. And if we look at the left side of the screen here, probability of cancer, if the PSA is between 4 and 10, which is the typical area that most people come to us at, 25% of people have prostate cancer. On the flip side of that, 75% of people don't. So PSA picks up 80% of cancers, but 80% of people with an elevated PSA don't have prostate cancer. That's a problem with the PSA test. So we've had multiple efforts to improve the specificity of this, to help us detect cancer more accurately and not to pick up those false positives. So we've looked at a number of different things, the PSA velocity, PSA density, we've looked at age-specific reference ranges, percent-free PSA. Most prostate cancers make a form of PSA that's bound to proteins in the blood. The higher the free PSA, the less likely they have cancer. But these all have their own, none of these are perfect. And the PSA test is not perfect, but it's still an amazing screening test. This is and a lot of the work here has been done at our center Dr. Parekh, Dr. A whole research institute here has been amazing at working with this and at supporting this and looking at other testing that we can do. The 4K score in particular is Dr. Poonen and Dr. Parekh were the top people on this in these tests, and we've shown how important the 4K score is in trying to exclude those patients with less aggressive cancers who don't necessarily need to be treated, because we want to get the people that we want to diagnose prostate cancer in those men who need treatment, and not men that it can be just watched on active surveillance. So a whole variety of serum tests, some urine tests, including the PCA3, are available now. We're using multiparametric MRI. Again, this is revolutionary. 15 years ago, this was revolutionary. Now it's standard of care because of a lot of the work that has been done at our center at the University of Miami. So just to conclude, basically, prostate cancer is a steep rising age incidence after age 50. Family history and race are significant risk factors. High competing mortality. Okay, there's a lot of people out there with heart disease and COPD and multiple risk factors who probably are going to live 10 years and to look for cancers in them. And this is where they got into trouble with Biden. I think it's all speculative, obviously, because I don't have his medical records, but I would say that, you know, a primary care doctor was probably looking at him, and he probably didn't look, he looks kind of frail. And so why are we going to rush to look for a prostate cancer in a gentleman like this? Well, it backfired, obviously. There's a high incidence of incidental autopsy cancer in many people too. 30% of men in their 50s, 70% of men in their 80s have a small focus of cancer that doesn't really do anything. So what I would say to end this all is that there are two totally different areas right now that approaches to PSA screening. The U.S. Preventative Task Force on the left side has given PSA indiscriminate PSA testing a grade C, meaning that it does equally harm as good in patients in doing prostate cancer screening. And they recommended that for the men ages 55 to 69 years old, a shared decision approach should be taken, that you should discuss the risks of screening, the false positive rates, and then the possibility of having treatment for unnecessary treatment for disease that is pretty low grade and not very aggressive. The AUA has come up with a little bit more specificity in their guidelines, and they do recommend that clinicians should engage in shared decision making for people in whom prostate cancer screening would be appropriate, based upon the person's values and preferences. That PSA should be the first line. A repeat PSA should be done. When the PSA comes back elevated, repeat it, possibly with a secondary marker like the 4K score, the PCA. Clinicians may begin prostate cancer screening and offer PSA testing to people between 45 and 50 who are at high risk. Patients 40 to 45 are people at increased risk for particularly those. There's a whole group of germline mutations. We also often think of breast cancer and BRCA testing for those. There's a lot of abnormalities in the BRCA testing for men and that may lead to prostate cancer, pancreatic cancer, and colorectal cancer. So that's another area of active investigation now. And one of the things that the AUA recently changed was that clinicians should offer regular prostate cancer screening every 2 to 4 years for men aged 50 to 69. Above 70, though, they do not exclude those men, as the U.S. Preventative Task Force recommended. Again, it's a shared decision-making, and you should look at the patient, the total patient. I follow patients in their 80s who haven't had a PSA in 10 years. If they're very healthy and they have a life expectancy more than 10 years, why would I not get a PSA? So I want to thank you all, and there's so many things that we could discuss on these talks, but it's such a wonderful, time to be able to connect with everybody, and I appreciate the opportunity to discuss these things with you. Thank you.
Thank you, Dr. Cava. Always enlightening and eye-opening. So all of our experts, if you could come on camera now so we can start our Q&A session, which we've got a number of questions that have come over the Q&A box. And we also have some that had been sent to us ahead of time. So let me begin with some of these. And you all gave us so much information, like Dr. Cava, for instance, on the whole Biden issue, that's had the entire nation or the world having this conversation. So when do men start? We already know colonoscopy, for instance, has a 40 or 45 year right? That's when you should begin. But then what do we say about starting your prostate check? When and when do you stop? It's controversial and confusing.
It's a very controversial area. So my recommendation is that for those people between 40 and 50 years old who do have increased risk of having prostate cancer, whether it's they're based upon their race, based upon family history, based upon the BRCA mutation, and any other significant prostate cancer associated syndromes, then they should start at age 40 to 50. Beyond that, I even discuss, 55 to 60 to 69 is really the recommendation of the AUA for focusing on every 2 to 4 year screening. Again, below that and above that is based upon a shared decision with the patient. So I discuss these things. That's the amazing thing about what we do as urologists. We have time to discuss these issues with our patients because they're not simple. They're very complex, and the decisions you make are complex. When I look at my internist who has a checklist of 200 different things that they have to cover with me during a visit, there's no way that they could focus on something like this. So that's why I think the urologist is so important, and they add so much to society and to medicine because of the ability to discuss these issues, to discuss erectile dysfunction, Peyronie's disease, to discuss testosterone replacement. We have the time and we have the knowledge and the know-how. So
Yeah, you're absolutely right. And for men, it almost seems like the urologist should be part of the PCP team. Dr. Horoditsky, this question, I saw it come over the box and I think you answered, but I think it might be valuable to answer to our wide audience. This is a guy who says, I have no cardiovascular disease. I'm a healthy man. I don't smoke. I don't drink. I eat right. I exercise. Why do I have erectile dysfunction?
So some of it you can do as much as you can, and you still can have bad luck. So that is one factor. I think it's also important to look at other things like your age, some of the things that I addressed earlier, medications that you're taking, if there's stress or issues in your life, do you get morning erections? What are your hormone levels? And so there may be other things that are what we call organic factors, like low testosterone level or other issues going on there, but sometimes there's external factors. And the truth is, we do all that we can to live long and healthy lives, but there is some element that is out of our control. And so sometimes we even see patients who are otherwise very healthy and still develop erectile dysfunction as they naturally age.
Okay, how about this question on finasteride, the hair growth treatment? Can that contribute to prostate cancer?
well, actually, finasteride was studied in the late 90s, early 2000s. Actually, I think 2000, the article was released. It was called the Prostate Cancer Prevention Trial. And they used 5 milligrams of finasteride compared to a placebo. And they found that there was about a 25% reduction in developing prostate cancer in the men who were on the finasteride. So you'd say, well, why aren't we doing it? And for a period of time, we started using it as almost like a vitamin. It was incredible how much finasteride was being prescribed. But then when they went down to the more granularity in these studies, they looked at the grades of the cancer that were being diagnosed in those men on finasteride versus the placebo. And it turned out that the men on finasteride had higher grade cancers. It raised a lot of questions. There's still a lot of debate and contentious discussions about these. It's probably I think that there was an article about with 15-year follow-up, there was no difference in the longevity or the life expectancy in the men on finasteride versus placebo in this group. They all lived around the same amount of time, and so the data still is, there's a lot of debate about whether it's important. But what we do know about the finasteride is that in some cases it does cause symptoms that are not good adverse effects, such as erectile dysfunction and loss of libido. So it's a small percentage of people, and there's a lot of debate over how important that really is. So that's why we're not using it as much anymore.
Let's give this one to Dr. Masterson. I know you talked about the safety of testosterone therapy in your presentation, but still the questions keep coming. So this one asks, how safe is testosterone therapy, especially for men with an enlarged prostate and those on blood thinners for artery clotting? So already that person has another health condition. And Dr.
Yeah.
Kava, you can get rid of the screen so that we don't have to see your wonderful presentation that we've already seen.
Oh,
If you
sorry.
can do it, if not, no problem. Dr.
Yeah,
Masterson.
so in regards to the blood thinner, testosterone therapy doesn't have any interaction with any blood thinners. What it can do though is increase your red blood cell count. As far as enlarged prostate, no one really knows for sure. There's very mixed data to say whether or not testosterone therapy is going to cause physical enlargement of the prostate or worsen any of those prostate BPH symptoms. So generally, it's considered safe.
Okay. Here's another one for you. How about the GLP-1 medications that it seems the entire nation is on for weight loss surgery to help manage obesity and improves men health outcomes? Any contraindications? Is this all good, going in the right direction in your specialty area?
Well, one of the things about the GLP-1s, managing weight loss is important, and so they serve a good purpose, and there's a lot of benefits to the GLP-1s, the agonists. The one thing that I would say though that they're finding, and it's an interesting curiosity actually, that it causes muscle mass reduction. And so people are now starting to look at whether testosterone replacement should be a consideration for some of these patients, to rebuild some of that muscle mass. So sarcopenia is a big problem with the GLP-1s, and there are some active studies ongoing right now looking at this. And
So it might be used in conjunction with the GLP-1s,
yeah.
possibly?
I'm not advocating it yet because it's not out there yet, because the data are not so clear, but this is something that people are looking at right now. So I would say in about 5 years we'll be able to tell you more about this.
True, since the GLP-1 drugs just, took over by storm, but we're learning more every day. Dr. Horodisky, this question is from someone, obviously a senior, who says, what can be done to increase ejaculate volume and velocity?
So, ejaculation can be affected by a number of things. So, we do see that um, the ejaculatory ducts open right at the base of the prostate. And so, what we find is that some medications, like a commonly used medication, tamsulosin, that relaxes the prostate, which normally squeezes when you ejaculate to help push the semen out. Those medications can decrease the semen volume, or you even cause something called retrograde ejaculation, where the prostate doesn't really close and semen goes backwards into the bladder. The same thing can happen after prostate procedures to open the prostate, because they have the same effect. So it depends on what this person's factors are, but those are some common things that can cause this.
You made a comment in your presentation that caught my attention, and I thought perhaps it required a little further explanation. How does excessive pornography lead to erectile dysfunction?
So we don't really know yet, but the thought is that some patients, it's generally seen in younger men who consume excess pornography. So this is, daily consumption, using it with normal masturbation, that it changes how their brain responds to normal stimuli. So when they're in a sexual situation with a partner, they don't have that same input, which is when they're using porn is exactly what they want in that moment. And real life doesn't work that way. And so it can be harder to have the same level of arousal, or which then translates into difficulty with erections or even reaching orgasm as a result.
Very, very interesting. I thought I needed to follow up on that. And Dr. Kava, some of the questions on all the different procedures that you talked about, the treatments and interventions, are how much experience does UHealth and your team have doing these, and all, like the aquablation and the TURP and all that? And is this all done under general anesthesia?
I would say that I'm thankful for being here. I really am. I think that most urologists will specialize in maybe 2 or 3 of these procedures. And I can only be grateful for Dr. Parekh putting together a team that really can cover just about every one of these options. We have people focusing specifically on HoLEP procedures. HoLEP is done by less than 2 to 3% of urologists. And I have 2 urologists here on our faculty that do HoLEPs, which is incredible. We have 2 or 3 people that do the aquablation now. We have one person that does robotic assisted simple prostatectomies, which is an incredibly technically challenging procedure, but he's incredible at doing it. And the UroLift and all the minimally invasive approaches, we have a variety of different people doing these as well from our faculty. So I think that once you get in the door, we can lead you. If we think, again, the wonderful thing about being here is that we're all collegial and we all support each other. And so if we find that if I find that somebody would be better served with a procedure that I don't offer, I offer it to my colleague and I talk to him about my colleague about it, which is an amazing thing. We just about every procedure is covered here.
Yeah, I know, and you speak with such humility, but all of you are indeed the dream team. And to have this amount of experts under one roof, all working in this team effort is pretty incredible. So, as you see there on your screen for everyone, and I thank you all for the privilege of your time, generous with all the information to the benefit of this incredible audience. And thank you to the audience for being so interactive with us. So there on your screen, you see the contact info for our urology experts, including the QR code if you want to shoot that. UMiamiHealth.org/urology for the appointments. There's the number on your screen, 305-243-6090. Thank you all so very much for being with us tonight. If you want appointments, if you want to reach out to them, they're there for you. So good night, everyone. Please stay safe out there and stay healthy. Good night.
Thank you.
Thank you, Ileana.
Thank you.